So homologous repair pathway is essential to repair any of the double-stranded DNA breaks that occur in the human genome, say because of extraneous exposure to ionizing radiation or chemotherapeutic drugs, etc. And these are primarily coordinated. This pathway is coordinated by BRCA1 mutation, BRCA1 gene, and BRCA2, ATM, etc. There's a whole array of genes that coordinates this pathway. So any defects in any of these genes could be a mutation or could be an epigenetic alteration, could lead to what's called homologous recombination deficiency, or HRD for short. So we know that in solid tumors, especially in ovarian cancer, HRD score is a predictive biomarker, in the sense any patients with over 42 HRD are quite receptive to treatment using PARP inhibitors or platinum-based chemotherapies. And in breast cancers, in prostatic cancers, it's also shown to have a prognostic value, but no one so far has looked into hematologic malignancies. But I do believe that it's extremely relevant. Well, firstly, we know that several of the patients, at least studies have reported that patients with AML and MDS do have frequent germline predisposition disorders, many of which involve genes involved in HRR pathway. And secondly, there is an increased risk of association between the treatment using PARP inhibitors for a solid tumor and developing therapy-related MDS. Now, we don't know if the risk is because of PARP inhibitors, but it might be that these patients are inherently susceptible for AML MDS because of underlying HRR deficiency. And further, there are several preclinical studies out there that have shown some promising results using PARP inhibitors in AML, in MDS, and as well as in ALL. So that's why we designed this study where we looked into the HRD score of a series of AML and MDS patients. So we calculated the HRD score from the microarray data, chromosomal microarray. I am a molecular pathologist at MD Anderson, and I am the head of the microarray section in the molecular diagnostic lab. So we looked at the consecutive treatment-naive patients, extracted the HRD score by calculating the LOH, TAI, and LST scores, putting them together, the final HRD score, and we assessed the distribution, the frequency, any clinical pathologic associations, and the prognostic value. It's very interesting that we found that the patients with higher HRD score were more frequent in patients with complex karyotype and in patients with TP53 mutations. We also looked into whether, so because of that, we focused most of our analysis only in patients with complex karyotype subsequently. And among those, we found that there was actually no significant difference in the median number of chromosomal abnormalities between those that had a lower HRD score or the higher HRD score, but patients with P53 mutations did have a higher HRD score, but not necessarily different number of chromosomal abnormalities. And when we evaluated the outcomes, we noticed that the higher HRD score meant a poor outcome. It was, and then we tried to identify a cutoff score where we were able to separate a group of patients with very bad survival of 3 months, and these showed HRD greater than 12, and patients with HRD less than 12, where the outcome was relatively better with about 9 months. And we also performed the univariate analysis, so HRD score, age, in addition to complex karyotype and P53 were prognostically significant. And by multivariate, however, it was just the age and HRD scores. And because of a strong association of HRD, high HRD with the complex karyotype in P53, we performed a subset analysis focusing on only complex karyotype and TP53 mutated cases, both together. And we saw that the HRD score actually separated them again. So basically, we conclude this study sort of generates a hypothesis that it is worthwhile to look into drugs targeting the HR pathway in AML and MDS patients. And what's more important is it may not work in all patients. We have to be quite selective. Based on our study, we do believe that patients with a high HRD based on the chromosomal microarray data, especially in patients with complex karyotype and TP53, might be an optimal subgroup to first explore these new drugs.